Everyone. We will be starting soon.
I told you. Oh, shit.
We're doing it all.
Hear you, they can't hear you.
I just don't know what else to say. Happy Bobby Bonilla Day. There you go. It is Happy Bobby Bonilla Day for anybody that cares. Besides, that's just no paying that money. It's 1.19 mil. Let's see, another 9 years. He's been retired for how long? I don't know, but he'll. It's played the game right. Sure. Try it now. Good morning. Can anyone hear me?
Hey, Matt, yes, we hear you.
Excellent. Sound is always wonderful. Good morning, everyone. We're here for the July LTSS meeting, Subcommittee of the MAC. If you're here for that, then you're here for the right thing. I like to say that. Pam, do you want to go through the stuff?
Sure. I'm going to start with attendance. All right. And maybe let us know if you are attending in person or via webinar or by phone. All right. Abigail Foster. Allie Cronley. Andrea Costello.
I'm here, and I'm here virtually.
Thanks. Anna Warheit.
Good morning, this is Anna.
Carol Marfisi. I know you are here. So Carol's here. Neil Brady. George Fernandez. Ginny Rogers. Jay Harner.
Morning.
Morning. Are you via webinar?
Yes, virtual, sorry.
Okay, great. Kathy Cubitt.
Good morning, I'm here virtually.
Morning. Laura Lyons. Linda Litton. Lloyd Wertz.
Lloyd Wertz present in person.
Hi, Lloyd. Lynn Widener. Michael Galvan. Folks who are on the line, if you could mute yourselves, we're getting some background noise. Shell Garrett. Padrag Tangni.
Yep, here in virtual.
Hi. Natalia Gomez.
Shell here
Good
in
morning.
person.
Good morning, everyone. Natalia Gomez here virtually.
Morning. Rebecca McTaggart.
Yes, I'm here and I'm here virtually.
Ryan Johnson.
Present virtually.
Hi. Has anyone else who, any other members joined since I started the roll?
Yes.
Hey, Pam, Shell
This
Garrett's
is
here in the
Laura.
room.
Okay, Shell Garrett in the room, and I'm sorry, who just spoke?
Laura Lyons.
Hi, Laura.
Hi, Laura.
Anyone else?
Yes, this is Abigail Foster, and I'm here virtually.
Okay, great. Anyone else? All right.
Hi, Pam, this is Paula. Neil Brady has joined. I think he might be having some trouble unmuting.
Okay, great. All right. Great. On to housekeeping. Oh, I'm sorry, I should have said this at the top. This meeting is being recorded. Your participation in this meeting is your consent to being recorded. This meeting is being conducted in person and as the webinar. To comply with logistical agreements, we will end promptly at 1 p.m. To avoid background noise, please keep your devices muted and the microphones off unless you're speaking. If you're attending the meeting in person, please keep background noise to an absolute minimum. The room is fitted with ceiling microphones that pick up everything. One of the chairs will report in-person attendance. Remote captioning is available at every meeting. The CART captioning link on the is on the agenda and in the chat. It's important for only one person to speak at a time. Please state your name before commenting and speak slowly and clearly so the captionist may capture conversations and identify speakers. Please keep your questions and comments concise to allow time for everyone to be heard. Webinar attendees may submit questions and comments into the questions box in GoToWebinar or use the raise hand feature to be put in queue to speak live. Those attending in person should use one of the microphones and wait to be called upon to speak. The tabletop microphones are reserved for committee members. Microphones are limited, so you may need to wait for OLTL staff to bring one to you. The general public should use the microphone on the stand in the rear of the committee tables area. OLTL staff are available for assistance. Before speaking into a microphone, use the power switch on the top middle of the microphone body to turn the microphone on. The switch should be pushed toward the end of the microphone you speak to. When you're finished speaking, push the same button toward the bottom of the microphone body to turn the microphone off. Time is allotted on the meeting agenda for 2 public comment periods. If you have questions or comments that were not heard, please send them to the resource account email found at the bottom of the meeting agenda and on the LTSS Subcommittee webpage. In the event of an emergency or evacuation, everyone must leave the building and assemble in the First Responders Plaza. OLTL staff will be available in the safe area in front of the elevators to provide any assistance. Please see the back of the agenda for more evacuation information. All right, thanks. And just to go back to the attendances, and just because we started right at 10, has anyone else, any other members joined since I last asked?
Good morning, this is Neil Brady.
Okay, hi. All right, I'll turn it over to Matt and Julia.
Thank you, Pam. I believe the background noise problem was me. Does anybody hear that still?
It's better.
Okay, thank you. Is Kathy available? I don't know if you wanted to handle that now before we get started with everything.
I'm here. I noticed.
Pardon me? Kathy?
I'm sorry. Can you hear me?
Yes.
I'm sorry. I think it might fit with Juliet's updates because she has some slides related to what I sent around.
Fair enough. Then on to you,
Thank
Juliet.
you.
Good morning, everyone.
want to welcome everyone to the LTSS Subcommittee meeting. I want to give a special welcome to our sports coordinators, sports coordinator supervisors who are joining us on the agenda today. So I look forward to that discussion and presentation to the LTSS Subcommittee members. For our members of the public who have joined us, I'm just going to give a quick reminder that the SCs will be presenting to the LTSS Subcommittee members and taking questions from the subcommittee members. They will not be taking questions from the public or responding during the public comment period. We'll do any follow-ups for any questions that folks may have, as we do as a normal course of the LTSS service meetings. All right, a lot on the budget today, but I do want to say, I'm coming back from a week out of the office and a week out of the country, so I had a lot of catching up to do. And part of that, unfortunately, was coming back to the Department of Justice issuing an opinion that is very alarming and can be very, very unsettling, and for some folks downright scary. So I wanted to take a few minutes to acknowledge that Department of Justice opinion that seems to attack some very long-standing policy and law, or counters, I should say, that have been very clearly laid out through the Americans with Disabilities Act, the Olmstead Decision, and the Rehabilitation Act of 1973. And so, I did want to say that this is just an opinion, all right? And as we have in past opinions, we read the opinion and we go about our day and our mission. And our mission has not changed here in the Office of Long-Term Living. Our policy has not changed in the Office of Long-Term Living. And so we will continue to do our work and our efforts in ensuring that everyone that we served is served well with dignity and respect in the communities of their choice, achieving the goals that they set forth and identify. And every member of the Office of Long-Term Living understands that mission and is moving and continuing to move in that direction. What I do also need to point out is that this is a pivotal moment in time. An opinion like this can, in my opinion, set up the White House to double down a target and a focus on HCBS waiver program. And I bring that up because this is a moment the stakeholders and the public need to respond. As a reminder to folks may or may not know, because these have been around for a really long time, since the 1980s, or since Randy has invented dirt, as he might say, they are optional, all right? Individuals who need long-term services and supports have had to fight hard for the option to have community services, and unfortunately they remain an option. They are not a mandate. They are not a requirement of state plan. And so this is a moment that challenges that long and welcomed understanding that we have here in the Office of Long-Term Living. So it did need to be said, and it does need to be said for everyone on this call who understands the importance of home and community-based services, that now is the time to be engaged, to spend time educating, and then to ensure that people understand the importance and the need to protect home and community-based services. So it is an opinion. It has no immediate consequences to our program here in Pennsylvania, okay? So I just want to kind of give folks a moment to breathe on that. All right. I also want to acknowledge that it's July 1 and I don't have a budget. So I can't answer any questions on the budget, but this budget will be critical to kind of future years. And we are going to be looking very closely when that budget is enacted, and we'll then look to administer the program as best we can, as we have had successfully done so over the past many years that these programs have been developed and put in place. So wanted to start off with that before I got into my usual routine. We'll go through the agenda. I'm getting reoriented. For folks who are online, we have a different view in the room, so I'm getting myself oriented. Okay, there we go. So For the agenda, the usual procurement updates. We're going to look at some the federal proposed and final rules for folks. Have an update on the Rural Health Transformation Plan, Human Services Licensing Annual Report, Adult Protective Services Annual Report, the Omnibus Budget Reconciliation Act waiver, and the Community Health Choices waiver, and the Inter-RAI software upgrade, and some staffing updates and other items. So I'll try to work through this quickly. So for procurement updates, for folks' awareness, on June 1st, 2026, we canceled the RFA for the re-procurement of the Community Health Choices program. In addition, we also issued a request for information for the current Community Health Choices Agreement and for an anticipated re-procurement of the Community Health Choices program and plan. So for the request for information, that opportunity is still open. There are approximately 2 weeks left. The deadline is July 15th at noon, not noon 01, but before noon. We encourage everyone and anyone to submit your comments, thoughts, ideas, good, bad, otherwise, via the comment process on the e-marketplace, and the details are all there. We want to hear from as many people as possible, so I put that out there. So what does this mean? This means that the CHC program will continue to operate under the current CHC-MCO agreements until further notice. I'm pretty used to me saying that, so nothing has changed. Any questions about the past RFA goes to an RFA email box with our good folks at Department of General Services, and that is RA-PW, RFA questions@pa.gov. If you have questions related to the request for information, there is a dedicated email box for that, or a resource account, and that is RA-PW RFI comments@pa.gov. All right, so lots happening at the federal level. We want to make sure that folks have every opportunity to be engaged. This is, as I said, the moment to be engaged, and there's lots of opportunities, so I hope and encourage folks to have your voices be heard. On June 1st, 2026, the Centers of Medicaid and Medicare Services released an interim final rule requiring that certain adult Medicaid applicants and enrollees must, as a condition of Medicaid eligibility, meet an 80-hour per month work requirement through employment, education, work programs for community service. This rule also includes state data reporting requirements and establishes requirements for how states must assess and verify compliance and communicate the new requirement to Medicaid applicants and beneficiaries. There is a fact sheet, if you don't want to read the many, many pages, on that interim final rule, and we have the link to that CMS website in our package that is available as a download and certainly emailed out via the listserv. Public comments for the interim final rule are due by the end of July. And so you can submit those comments via the Federal Registrar. Again, this is a federal opportunity to submit comments. Folks may think that, oh, well, I'm an LTSS, this does not apply to me. I can assure you it does, because we are one big ecosystem, and what happens in one area impacts other areas. And, you know, we have a lot of direct care workers who may also be in the Medicaid expansion population, so this may be impacting them. It may impact our hospitals, et cetera, because when you have folks who are not eligible, who would otherwise be eligible, or if the red tape is too stringent, then you get more uncompensated care. More uncompensated care in the system backs up a lot of things, has major implications to the populations we serve. So I say this is, we're all interconnected, so if you don't think this applies, take a moment, think about it, talk about it, and here is an opportunity to comment. Another opportunity to comment. On May 20th, 2026, the Centers for Medicare and Medicaid Services released a proposed rule for public comment describing alternatives to modify the limit on the total payment rate and other requirements for state-directed payments in Medicaid managed care. It's a mouthful. This rule addresses requirements pertaining to prepaid inpatient health plans, prepaid ambulatory health plans, requirements pertaining to contracts between states and managed care organizations. This would impact everyone in our CHC program. To provide payments under a risk-based contract for services and associated administrative costs that are actuarially sound. It sets a limit for certain targeted Medicaid payments and Medicaid fee-for-service programs like our OBRA Act 50 programs. CMS is accepting comments on this proposed rule for 60 days, and so the comment period for this proposed rule ends July 21st, 2026. And interested parties can submit comments via the Federal Register. Now, for folks who may not be aware, there's significant impact potentially to our Community Health Choices Managed Care MCO payments, agreements, and program, specifically because we use state-directed payments. It is a common and important tool that states use to kind of help ensure that we have funding available for our Medicaid program. And there's a lot of funding that gets tied up into those state-directed payments. And so when that process is restricted or capped, it essentially has a downhill effect of restricting and capping ways in which states can adequately fund Medicaid programs. So the implications are huge. So particularly for our nursing facility folks and friends, this has a very big impact on that particular state-directed payment. For home care agencies, it has potential impact in that it may sort of create a situation where we would have to consider removing a minimum floor rate for PAS agencies. So just for folks' awareness, these are some pretty big policy changes that are being put forward for your comments, and I encourage you to think about them and take the opportunity. Another one, Federal Proposed and Final Rules Update. On June 2nd, the Office of the Management and Budget proposed to revise the guidance for federal financial assistance to improve government-wide policies and requirements related to the management of grants, cooperative agreements, and other forms of assistance. The Federal Office of Management and Budget is proposing revisions that would improve transparency, accountability, and oversight for federal awards across the federal government. This office also proposes changes to reduce recipient burden. The listed federal grant-making agencies propose conforming changes to their respective adopting regulations, or in the case of some agencies and other entities, establishing new adopting regulations or policies. The proposed changes reflect the administration's commitment to transparency, accountability, and proper oversight for the federal grant-making process. This is all put out as part of the federal proposed rule. Comments on this rule are due on or before July 13th. Via the www.regulations.gov website. So this has sort of minimal impact to the Office of Long-Term Living specifically. We don't necessarily issue a lot of federal grants. There is some impact to us, but we're not sort of administering a lot of federal grants. However, there are many agencies and organizations tied into our LTSS ecosystem and the Medicaid programs. We thought this was very important for you to be aware of. All right, moving on to the Rural Health Transformation Plan, RHTP updates. Most of the RHTP updates will be pushed out via their dedicated listserv for RHTP. We encourage everyone interested in the Rural Health Transformation Plan and DHS's good work in improving rural health outcomes, access, and opportunities to enlist in that listserv and or connect to the RHTP via DHS's Substack. We will not always have updates in the Office of Long-Term Living regarding RHTP, so please do not depend on this subcommittee for those updates. So there have been several projects that benefit participants who receive services by the Office of Long-Term Living that have been approved for funding, and we wanted to take a moment to celebrate that. So we have some projects that will include the continuance and the enhancement for the Nursing Facility Quality Investment Pilot Program from the Long-Term Transformation Office of the Department of Health. We partner very closely with them. We have projects related to the expansion of our living independence for the elderly, or LIFE services and programs, specifically via LIFE Northwestern Pennsylvania, or NWPA, for older adults in rural northwestern, central, and northeastern Pennsylvania counties. I am very particularly excited about that because it means we will have more LIFE program access in more of our counties. As you know, it's been a goal of ours to have this be a service accessible in every single county. We were at 13 for a long while. So through the RHTB process, we're bringing, I know, immediately 4 additional on. We hope to get 5, so that will leave us with 8 counties left. So we're whittling it down. It's still a goal. In addition, the paramedicine program expansion for rural participants post-hospitalization will be getting underway, and that will allow elderly and older adult participants in rural areas to be seen at home by paramedics rather than going back to the hospital for follow-up. So I think that's huge. We're meeting people where they're at. The Office of Long-Term Living team is very much linked into this, as is Dr. Appel, our medical director, who's in the room with us today. In addition, we have programs related to expanding certified nursing assistant training opportunities for staff in our rural nursing facilities. As you know, the direct care workforce shortage is real, very much so in our rural areas, so we are excited about this opportunity. And lastly, enhancements of the Pennsylvania Link network that helps older adults and people with disabilities to be connected to resources to help with home care supports, long-term care planning, transportation, Medicaid applications, and other resources. Now, just to note, the reason why it says older adults here, not older adults and people with disabilities, that I added, is because this is under a section really dedicated to aging as part of the Rural Health Transformation Plan. So it's not an oversight. I always just like to put those two together. So again, listserv, website, Substack, if you want more information on RHTP. Okay, our folks have been busy. The Bureau of Human Services licensing, for folks' information, this is the bureau that licenses all the personal care homes and assisted living residences across the Commonwealth, over 900 personal care homes, over 60 assisted living residences. This is the team that licenses them, and every year they put out an annual report of their findings and summarizing any licensing activities that they have taken, trainings, supports, data on who's being served and where. So the report describes the facilities inspected and licensed, the annual trends that we're seeing in the number of licensed facilities going up, going down, changes of ownership, the needs of residents served in personal care homes and assisted living residents, types of violations found, natures of complaints and incidents received and investigated, and our enforcement action, plus the additional BHSL activities, such as the resource coordinators that have been brought onto our team to help particularly the personal care homes serving individuals with receiving SSI to really connect with resources, because we really want to help strengthen the personal care homes serving our most vulnerable, and in particular those of the lowest income. The Bureau of Human Services licensing team also oversees adult protective services for adults with disabilities ages 18 through 59. And they have posted their 2025 Adult Protective Services Annual Report to our DHS website. So under Act 70 of 2010, when this was originally enacted, DHS is required to prepare this annual report to the Senate Health and Human Services Committee and the House Health and Human Services Committees about the program and the services that are performed by Adult Protective Services. The report is here. It reports out on all of their activities. For example, the over 15,000 reports of need received by that team, In the past couple of years, that is in there, the breakdown of that, alleged perpetrators, where incidents have been reported from, things of that nature. So I encourage you to take a look at that. I know I'm going out of time, but I'm going to get through this as fast as I can. So the OBRA waiver update. So we have received approval for the OBRA waiver renewal from the Centers for Medicaid and Medicare. So I was really happy that we got that before July 1st. So we got that on June 18th. We're grateful to our federal partners. That renewal continues our authority to provide services to participants between the ages of 18 to 59 when they initially enroll, who have developmental disabilities, and provides a pathway to those home and community-based services. So there have been some changes included in the renewal. We had given a preview of what we intended, and now we have confirmation of their approval. So one is a teleservice option for behavior therapy and benefits counseling services. We revised language regarding our OLTL quality improvement strategy and quality monitoring process. We added beneficiary support services to the responsibilities of our Pennsylvania Independent Enrollment Broker, which is more critical now than ever, given all the additional redeterminations that folks have to go through, the shortened period for applications that people are facing via HR 1. We are hoping that this support service can help folks kind of work through all of that. And it also required service coordinators to include HCBS services settings requirements in all service planning activities. So that is just ensuring that we are complying with the community settings rule throughout our program. We have a link to the approved OBRA waiver on our website for folks who would like to dive into that in more detail. Additionally, when we do one, we do like to look at our other waivers to ensure continued alignment where possible, to kind of reduce administrative burdens and make the changes that make sense and be efficient and effective with our work resources. So we also had submitted an approval for a CHC waiver amendment. We received that approval as well. Again, both of these are effective July 1, 2026. This continues our authority to provide home and community-based services to participants ages 21 and over in our managed LTSS program, Community Health Choices. So again, some of these changes are very similar to what we put in the OBRA renewal. We added the teleservice option for behavior therapies and benefits counseling services. We added language to specifically address teleservice delivery of waiver services and the home and community-based settings rule. And we removed and modified outdated language throughout the waiver. That is also posted to our website. And again, we have to go through these applications and amendments whenever we want to make changes to the program, and at a minimum every 5 years, to ensure that we can ask CMS again to allow us to have the option of providing HCBS services. So that's the critical piece. These aren't rights, these are options. And those are the options we have to defend and fight for. Okay, the INTER-RAI, or the International Resident Assessment Instrument. You heard me talk about this a couple months ago. We are going through a software upgrade. We are moving from the version, I think, 9.2, don't hold me to that, to the upgraded version of 10, because the version 9 is not being supported. So all of the assessors who utilize the INTER-RAI, our Aging Well partners, our service coordinators, have been advised to start utilizing the version 10 assessment after June 26, 2026, and by July 6, 2026. So all the assessors and MCOs are now using version 10 for the assessments. So really good job, everyone. I thank you for your efforts and the time in doing those trainings. The official training course has been completed. It's been published by Daring Consulting, our approved training contractor. The INTER-RAI team is in the process of publishing the Pennsylvania-specific version 10 manual. So kudos to the quality team and all of our stakeholders we wanted something Pennsylvania specific because our program is for Pennsylvanians. And so very excited about that. And officially that work group, which includes multiple stakeholders and members of the LTSS Subcommittee, will close out on July 14th officially, and that project will be done. Of course, there will be ongoing monitoring, but that work group will be closed. All right, staffing updates, really critical ones. The first one is I want to share with folks, and I'm very pleased to report out that John Iyer will be starting officially as our new Bureau Director of Finance, officially starting on July 4th. John Iyer is a veteran of the United States Army. He graduated from Shippensburg University with a Bachelor of Science in Business Administration. He has been with the Commonwealth for 27 and a half years, including many different areas in DHS, the Office of Developmental Programs, the Office of Mental Health and Substance Abuse Services. He was the financial manager at South Mountain Restoration Center. He's been with the Office of Medical Assistance Programs for 5 years, and he has been working very closely with Dan Scher, our former Director of Finance, for the past 5 years. So he is very knowledgeable on all things DHS, and hope many of you will feel the same and welcome him to his new position. He also completed his nursing home administrative program at York College in 2015. So wanted to make sure folks were aware of that change. So we're celebrating that. We have another celebration that's more of a mixed bag for many of us in the OLTL family and the broader stakeholder group. I am here also to announce and share that although Randy has been threatening this since the day I started, literally as I walked into the lobby, he told me he was going to retire 3 years ago. It's like, hi, how are you? By the way, I'm Randy and I'm retiring. We do have a date 3 years later. And, you know, we want to take a moment to thank Randy for your service. Randy started his career in our field back in 1983. And he started with the Commonwealth in May of 1994, and he has been an incredible public servant for the last 32 and a half plus couple days, years. His official retirement date is coming up on August 15th, 2026, so it's coming up fast. This is his second to last LTSS Subcommittee meeting, so I wanted to make sure you knew at this one and not his last one. So you have another opportunity to throw things at him or come and see him. Yeah, he might not come for that one. Let's scare him off. But, you know, it's just been incredible, your impact to the long-term services and supports. You've been very much a public face for many, many, many participants and providers and partners across the 32 and a half years. And, you know, Randy does so much more, even beyond his public service here with us. It's just been an incredible honor to know him over these many years. And I did want to highlight because the type of man Randy is. And folks may not know this, but back in 2005, Randy, on his way at 7 a.m. in the morning, was walking by, and there was a house on fire, and without hesitation, he ran into it with another man from the community to help save a person from a house fire. And so this is just a testament to who Randy is, how Randy approaches his day-to-day. When there is opportunity, there is no hesitation to do the right thing, and his wealth of knowledge that he has passed on to so many leaders that he has grown in the Office of Long-Term Living Team is just immense and immeasurable. So we wanted to recognize that and say thank you, Randy.
Man, that was an old picture. Actually had dark colored hair and everything back then. Yeah, it's been a long journey. I started out, my background, I'm a social worker. I started out working in a large county nursing facility in Dauphin County. So I've worked for about 12 years on that side. I've also done work in, ICF, ORC types of facilities before I came to the state in '94. I first came to the state through the Department of Health as a family and children program manager. 6 years later, I moved over to the Department of Public Welfare at that point in time into long-term care, then moved over to running fee-for-service for a few years, and then back into long-term care probably in about 2005. So I've been back in long-term care for 21 years. My goal was to kind of, cruise out. I was overseeing the field operations teams that did different types of reviews and audits in nursing facilities, and it was well set up, and I was cruising out on that. And then this little thing called CHC concept came around, and thanks to the deputy who will not be named at this time, the little guy got me so involved in this program that I ended up running it at this point in time. So it has been a journey to switch over from a fee-for-service system to a managed care system. It has taken a lot of work. I've had the opportunity to work with a lot of people over the years, not just within OLTL, but throughout the state, throughout all the managed care programs, but more importantly, throughout working with advocates and participants and their family members to try to improve and provide them services so that they can stay living in the community. We talk a lot about numbers, but 35 years ago when I worked in a nursing facility, 90% or more of individuals got their services in nursing facilities when they needed long-term care services. We're now close to 80% of those individuals getting those services at home in the community where they want to continue to live. That is a testament to everybody in this room that has worked over the years to make that occur. So it's been very grateful work to do that. I had the opportunity yesterday with my staff. I did a staff picnic and had the opportunity to let them know that they've done tremendous work moving forward. A lot of times we hear about the issues or concerns that are in the program, but 95% of this program is running fairly well. Do we have issues? Yeah. We have issues in any public service program like this. We work on those issues. We work with the MCOs to get things corrected. We work with the participants. So the dedication has to be to all the staff that work on this. I appreciate the opportunity to work with all of you, and hopefully we'll cross paths in the future. So thank you.
All right. So with that, should I pass it on?
We can pass it over to Lloyd.
Yep.
This is Kathy. I'm wondering if I could give make my motion now.
Please do.
Thank you. I would like to offer a motion to give a formal commendation from the LTSS MAC and a statement of gratitude for Randy. I circulated this statement. I'll read now. The LTSS MAC wishes to congratulate Randy Nolan on his retirement and acknowledge his distinguished public service to Pennsylvania. For over 32 years, Randy has been a model public servant, demonstrating outstanding leadership and the highest standards of integrity in performing his duties. He leaves large shoes to fill at the Office of Long-Term Living, and his hard work and dedication will be remembered by all of us who have the pleasure of knowing Randy. His sincerity, responsiveness, and sense of humor will be greatly missed. Randy has had a significant impact in Pennsylvania, including his leadership in helping Pennsylvania transition its long-term services and supports system from a fee-for-service model to community health choices, a managed care model. In addition, his strong work ethic and tireless efforts were evident in helping meet the challenges presented by the COVID-19 public health emergency and in Pennsylvania's LTSS rebalancing work to serve more participants at home versus institutional settings. With this motion, the LTSS MAC formally expresses our sincere gratitude and commends Randy for his outstanding public service, congratulates him on his well-deserved retirement, and wishes him all the very best for good health, happiness, and success in the future. So I hope all LTSS members, I've heard from some, but I hope they'll join and vote in support of this motion. Thank you.
Thank you, Kathy. Is there a second?
This is Pam Walsh. I will second it.
Okay. And is there anybody in favor?
Aye. Aye.
Anybody opposed? Abstentions?
Aye.
Seeing none? The motion carries. Thank you, Kathy. With that, I'm going to pass it over to Lloyd and Pam.
Thank you. Just briefly related to your last section, not to Randy. I've got a few comments for that later, but Julia, when you refer to the use of the rural investment funds that we're getting in, you talked about support for a lot of things. One of them being the workforce that is very, very endangered for public services. And my recollection of the use of those funds was that you're not allowed to use it for ongoing operational purposes. Is that in mind as we continue to use it for those purposes that you mentioned?
So it's, from my understanding, not to be used for operations already in place, on those sort of general ongoing operations. So that's kind of why it can't be used to, lift up rural hospitals operations purposes or administrative purposes. It wasn't meant for that purpose. So all of these sort of programs, these are sort of program enhancements. So for example, the LIFE program and investments, those are for new centers, not current centers. Those are for expansion into rural areas. So it's not sort of operations in place, but new things coming in. I hope that's helpful. Does that answer, clarify?
It's great. I'm hoping it's right, but it's great.
I got the nod from my chief medical officer, Dr. Powell, that I was right on that, so you can take that to bank.
Pam, I can lead in, or you can lead in, your choice.
Maybe I'll just say a couple quick things, and then I know you want to talk about the lawsuit, right?
Yes.
Okay, great. So I'll just lead in by saying that since this is Pam, since our last LTSS sub, we have not had another meeting of what is I think now called the HR1 Informational Committee, maybe. But we do have another one coming up on July 14th. So at the next meeting of the LTSS subcommittee, we will have a report from that. But as everyone heard from Juliet, the interim final rule that came out has really kind of thrown a wrench into things and is a cause for a lot of concern. States including Pennsylvania, had been doing a lot of work preparing to implement HR1, including a lot of work getting ready to use existing data to identify people who will be exempt from the community engagement requirements based on medical frailty. And they were doing that based on guidance that they had been receiving in conversations with CMS. The interim final rule took everyone a little bit by surprise by making a significant change to the substance, really, of that exemption by adding a component that the medical condition must affect the individual's ability to work. And so as a result of that, all the states which have, really been having to work on this already, despite the lack of guidance, are having to some extent go back to the drawing board to get ready to implement this. Also, it's a big concern because this would narrow the scope of people who can get an exemption from community engagement. And again, we're talking about the expansion population with this particular with the community engagement requirement. So there's a lot of concern that, whereas before, the thinking was that this was an exemption for people who really need to stay connected to Medicaid in order to get to treat their conditions. This is more a narrowing it to people who can show that they're unable to work. So with that, I'm going to turn it over to Lloyd to talk about a very recent development.
Yeah, thank you. Thank you. Lloyd Wirtz here. I guess it was at last week's MAC, it occurred to a number of us who were in attendance, why haven't we filed, whether it's the Commonwealth or someone else was standing, why haven't we filed a significant legal action to enjoin these animals at the federal level from processing this issue beyond their scope and beyond reasonableness to the vulnerable population within our not only Commonwealth, but across the nation. And not having anything to do with the fact that we brought that up, that suit was filed. And that suit was filed with, I believe, 28 states who are members. It's very easily accessible. It starts, it apparently was filed in the District Court in Massachusetts, and lists a number of the things that you just heard Pam talk about as we went through the issuance of this latest interim final rule. I cannot believe that we as a nation can stand by and watch people who have no interest whatsoever in the welfare of anyone but the people they see in the mirror, and then process that and limit the funding to services to those people who they never see in their mirror, and believe me, and probably for the better, never will. So this lawsuit is a big, big deal in my opinion. It can be referenced and should be referenced to determine what type of action it is. It looks to be pretty complete to me. Of course, just because we file a lawsuit doesn't mean anybody's going to pay much attention to it. We certainly can see that our leadership seems to not pay much attention to lawsuits, except for his own. We need to be aware of it. We need to read it. We need to take it to our local legislators. We need to take it to the folks within the House of Representatives and particularly the Senate, and point out why this is a bad idea, and point out why we will not.
Is here, Lloyd? I just lost the sound for Lloyd.
Yeah, that's the same. You've lost for everybody.
Okay, well, I'll just jump in until Lloyd gets his sound back and say that the lawsuit was filed by the attorneys general for I think it sounds like it's close to 28 states, as well as several governors, and I'm proud to say that that our governor has joined the suit, so we are part of the lawsuit here in Pennsylvania.
Got it. Helpful, Pam. Thank you.
All right. So with that, unless Lloyd's able to come back, I think maybe we're ready for public comments. I'll just turn it back over to you, Matt.
I think Lloyd was in the room, wasn't he? So we may have lost the whole room.
Do you think we can continue with everybody on the webinar? Hopefully we still got that. Okay, Juliet says they're working on sound in the room.
She also sent a message saying, but please continue with your HR1 update. But somehow it only went directly to me.
I think I was done with the update.
Yeah.
I think that the main development right now is the lawsuit, and again, just to restate what Juliet said, we are in the comment period for comments on the CMS's internal interim final rule, and CLS, and I know a lot of other organizations are making comments on the rule.
Hello, this is Juliet. Can you hear
Encourage.
us now?
We can hear you now. Just encourage others to make comments as well, particularly about how the IFR will affect Pennsylvania.
Can you hear us?
Yeah, we can hear you. Can you hear me?
The captioner can hear us.
We can. It sounds like you, Juliet. Can you hear me? This is Pam. Okay. Well, we can hear you.
I don't hear anything anymore.
Yeah, Matt, are you there? Can anyone? Is anyone able to hear me?
I hear you, but that's it.
Yes. Okay, good.
I hear you.
I'm glad. Matt, are you there? Huh. Juliet says the room Wi-Fi internet is fluctuating in the room. Oh, Matt was probably attending in person. That's probably the issue. Paula, was Matt attending in person? Do you know?
Pam, this is Paula. I think he was virtual.
Oh, I think he was virtual. Okay. All right. Well, are we able to move on to public comments? And if we do, will the department staff be able to hear them?
This is Paula. Let me look into that, Pam.
Okay. Apologies for everyone attending virtually. Okay. We're having technical difficulties. Okay. Juliet says they'll be able to see the captioner. So, Paula, it sounds like they'll be able to see the comments as the captioner takes them down. Are we able to take public comments?
Pam, this is Paula. I think as long as the captioner is able to hear us, I think that's the way to go.
Okay. All right. Are you able to take some public comments? Do we have anybody waiting for to comment?
I'm looking. We have.
Pam, can you hear me?
Yes, you're back.
Okay, fantastic. Nobody move. We have my trusty jabber and a microphone, so we're going old school here.
Okay,
All right,
that's
yes, let's move
that.
into public comments.
Okay, that's great. I believe we may have lost Matt though.
No,
Matt's in the room.
Oh, Matt's in the room. No wonder we lost him. Okay, great. All right, go ahead.
Anyway, Matt's been lost for a long time, so. Any public comment in the room?
Just think it needs to be noted that we have agreement that the lawsuit as filed will be included with the distribution of minutes from this meeting.
Yes.
I think we understood that to be the case. Thank you.
Paula, we do not appear to have public comment in the room.
Hi, Matt. This is Paula. I heard my name, but I was not able to hear what you said.
Are there any questions online?
So we do have Rebecca McTaggart has her hand raised. If we want to go to her.
Rebecca.
Hello, this is Rebecca McTaggart. I have been looking at HR1 and their recommendations for the work requirements. And unless I am incorrect and missed something, there doesn't seem to be any guidance for those people who are required to work or volunteer. There aren't any requirements about while they are working, looking for a job or looking for an opportunity to volunteer, whether or not that's going to be taken into account. I mean, we all know that the finding a job is not as easy as they're making it sound. Am I correct that that is not something that's in the guidance or being planned for?
So this is Juliet. What I will say is the guidance in some areas is very murky. In terms of planning for Department of Human Services, we've been doing a lot of planning to try and engage our community-based organization partners to identify and work together to ensure there's opportunities for volunteering. We're looking at ways of getting information out there, perhaps leveraging things like our PA Navigate, certainly working in lockstep with the Department of Labor and other departments to ensure that we can, as much as possible, highlight and offer opportunities for the individuals who will be impacted throughout our system. But since this is more in the Medicaid expansion population, I am not the lead nor the most knowledgeable in all of the pieces or elements on the DHS strategy, given that for the most part, the LTSS population would be exempt via age or via meeting the definition for medical frailty. So it may be something better served for the MAC, perhaps. Sorry, I can get back to you with answers. I just don't, I'm not the best person to answer them.
No, I appreciate it. I just think it's definitely a failing on, well, there's many failings in the part of the federal government right now as it relates to this, but it is definitely a failing of the government on the federal level not to think about this, because job market's pretty tough out there, and even volunteering is very strict. Thank you, though.
Thank you, Becky. I'm noticing the time. I want to just move into that. Learned.
Yeah, there's more time at the end for additional
Yeah,
public
we'll
comments.
come back to questions closer to the end, so we can keep time with our break and whatnot. So we'll move into the lessons learned while planning for service provision during large events.
So what I would say is
Carrie Zolak, yes. I am here.
I'm sorry if I murdered your name.
No, that is okay. Well, good morning, everyone. My name is Carrie Zwolak, and I am one of the Directors of Service Coordination at AmeriHealth Caritas Keystone First. So first, I want to thank the committee for inviting us to speak today on our lessons learned while planning for service provision during large events. This topic is certainly timely as our state's holding numerous celebrations. We're commemorating America's 250th birthday, and of course, the city of Philadelphia is hosting our FIFA World Cup. So on the next slide, I wanted to start with sharing the why of why we plan. So the why really becomes the driving force behind our actions at AmeriHealth Caritas Keystone First, and we have found that having the common why established keeps our entire team grounded, and we're able to see the common end goal. So planning, of course, allows us to be proactive versus reactive, as the health and safety of our participants is first and foremost our goal, and we know that our participants rely on the provision of these waiver services. So I'm going to speak about lessons learned surrounding the FIFA World Cup. Again, this is very timely, which commenced in mid-June and has impacted the city of Philadelphia. So on the next slide, I discuss our lesson learned number 1, where we learned how key it was to have a formal plan in place. So for the recent events, we started discussing the FIFA World Cup in March. We sought feedback from multiple key players, including the service coordination team, provider network management, transportation, and communications. We took the time to understand the scope of the event. We did our research, learning just how popular soccer can certainly be, and we developed a formal contingency plan. We made sure that the contingency plan was cross-departmental, as I mentioned, those key players, and approached it by identifying barriers to services and developing solutions. So each department contributed insight from its areas of expertise to address our participants' needs and reduce service disruptions. And we did make sure that the contingency plan was flexible to adjust as new information became available. For our lesson learned number 2 on the next slide, we knew as a team that this plan needed to come to life. So we knew how crucial it was for both internal and external communication to be in place in order to successfully implement and carry out our contingency plan. So from an internal communication perspective, this consisted of set weekly meetings where each team had representatives from each department where we review updates, we shared concerns, and we had the ability to discuss any needed next steps. External communication with our participants and providers was equally as important and included our service coordinators conducting monthly outreach to all of our participants leading up to the FIFA World Cup. As well as this gave an opportunity for us to share updates with the participants of information we had learned about the event through our research, identify any concerns, and verify that backup plans were in place. Text messaging was also utilized to alert participants of upcoming events, And email fax communication was also sent to all providers to make sure each provider had a plan in place. Risks. So bringing us into lesson learned number 3. So we knew that we needed ongoing review. So of course, when we thought of our service coordination and potential service provisions, we focused our providers on our care services, home delivered meals, transportation, and any other services we felt could be impacted. We did review ongoing external sources of information and found that enrolling in social media and text alerts from the City of Philadelphia provided ongoing communication and provided beneficial information to our plan. During the most recent FIFA event, we were able to gain from these text messages and website social media review additional information related to a specific area of Philadelphia that was to be particularly impacted by closures surrounding the FIFA Fan Festival. So it reinforced the need and benefit of the continued communication that we were able to bring that back, implement that into our plan, and get that information to potentially impacted participants. It also additionally, in addition to the services, we know that actual service coordination is important. So any traffic and parking challenges, barriers, particularly related to the events impacted by the FIFA World Cup, were able to be communicated out to our service coordinators as well. So they also did not experience any disruption in providing service coordination, visits, and communication with our participants. And so as we wrap up the World Cup in the next couple of weeks, we will continue to review lessons learned as an example of a large scale event. So thank you very much. Any questions?
Any questions?
Thank you, everyone.
Thank you, Carrie. Who is next? Taylor now.
Everybody, are you able to hear me? My name is Taylor Dowden. I am the Senior Manager at PHW for LTSS and Care Management.
Hold,
and today I'm also
pause. Oh, there you go. See, I had to look for the captioner, and she had paused. So
okay,
go ahead.
Perfect. Thank
Are,
you.
are we speaking too fast, Captioner?
I think you need to sit here. Oh no, she's got you, Matt. Try again, Taylor.
Good morning, everybody.
It just seemed like she had the captioner had trouble keeping up with the previous.
There you go. So we're good.
Okay, thank you.
Perfect. So for those of you who didn't hear, my name is Taylor Dowden. I am the Senior Manager of Care Management with PHW and LTSS. And today I want to focus on our lesson learned when we have large events across the state of Pennsylvania. So for this specific topic, PHW really wants to frame our lessons learned about the importance of preparing for these events in advance, not just responding once the disruption has already occurred. So we know that many of our participants really rely on these consistent services to remain safe in their home or their current settings. So we know that large events really can create challenges with our staffing, our transportation, provider access, communication, and our participant outreach. So our experience really reinforces the need to identify participants who are most vulnerable to these disruptions. And one of the big things we really focused on at PHW was our participant backup plans. So we made sure that they were meaningful, they were current.
Can't pick it up tomorrow?
You got to move closer to the jabber.
Okay, should I bring this mic with me?
Just give
No,
us
no,
a
no,
minute,
just use
everybody.
this one.
We're moving some things around.
Right over here. It's right over there.
All right, is everybody able to hear online now?
Yeah, you got thumbs up.
Okay, perfect. All right, so as I was saying, what we really focused on here at PHW was our backup plans. So we did some training with our service coordination entities to ensure that they were reaching out to all the participants, ensuring that their backup plans were current. They were aware of the events that were occurring, and that we also provided clear communication to our providers, transportation partners, our participants, their caregivers, and all of our internal teams at PHW. So if you were calling in to ask questions or had concerns, we could address those at those times. PHW's LTSS program description emphasizes coordination, participant-centered, cost-effective managed care, and includes attention to our after-hours and emergency staffing. SCs to participant communication, the SC's caseloads, and real-time information sharing about the participant and their encounters. The PCSP process also supports this approach because service plans include risk factors, measures to minimize those risks, and customized participant contingency or backup plans when crucial services are unavailable. The documentation should also reflect that participants are educated on how to notify the provider or SC of any gaps in care, and that the backup plan can be activated and safe alternatives are established. So our external emergency preparedness guidance support is really the same general principle as the Center for Medicaid and Medicare Services, and it describes the emergency preparedness requirements as intended to ensure adequate planning for natural and man-made disasters in coordination with federal, state, regional, and local emergency systems. So Medicaid-focused disaster planning guidance also highlights continuity of operational planning, use of risk assessment data, and cross-agency alignment to support Medicaid members during these disruptive events. So what we want to highlight here is a really strong approach is what we need to make sure we have a plan and a model in place to identify these risks quickly, communicate, coordinate those services, document any actions, and use after-action learning to strengthen our future planning for upcoming events. Lastly, we just want to focus on that we understand that to have an effective LTSS program, we need to ensure that we have continuity of care during large events, depend on planning early, coordinate, and clearly take accountability, not just respond on the day of the actual event itself. Any questions for PHW?
We'll keep the mic.
Last but not least.
Please pause as we bring up our next speaker, David Gingrich.
Thank you. Sorry, that was a little too loud. I'm David Guerin, the Associate Vice President of Managed Long-Term Services and Supports Home Community Clinical Operations. And we're going to talk about the lessons learned that UPMC has for planning large events, coordinating for services in large events, as well as how we handle just overall preparedness for our participants in program. When we become aware of a large event, so next slide, please. We always want to start focusing on the goals, right? And the main goal is to ensure that we're minimizing any participant or programmatic impact of whatever that event may be. Whether that was the NFL draft that was held in Pittsburgh this year, whether it's the American 250th or the FIFA that is happening now, or whether it's a snowstorm or large construction that we've become aware of. You know, the overarching goal is when we become aware of that to make plans in advance to ensure that we are minimizing any disruption for the participants or for the program in general. We also want to make sure that we have a plan because nothing is perfect and things will happen. And we have to have a process to ensure that there's communication or points of contact during the event to ensure that we're able to continue to proceed with, again, the provision of services or the payment of providers to ensure that things keep moving forward. And ultimately, just the continuity of operations. You know, the participants that we support rely on these services for life-sustaining reasons. And we want to make sure that we're able to be there, whether it's snowing, whether there's a traffic delay, or whatever the case may be, to ensure that, again, the lights are still on, the services are still being provided, and that we're able to look out for the participants that we are entrusted to. Next slide, please. So a lot of that starts prior to the event. I'm sorry. If you can go back one slide. Sorry, I'm seeing a different screen. So a lot of that starts prior to the event. You know, again, when we have the opportunity to know something in advance, we want to make sure that we are communicating with the participants, with the staff, and providers. That written communication, telephonic messages, and as well as communications within the portals, so that folks are aware of something is anticipated this time period. So that they understand that it is coming. We like to do that as far in advance as we can. So if we know of something being scheduled months in advance, we can start providing that notification. If it's a weather event, that may be a shorter notification, but we still want to get that out in advance of when that occurs. We also want to make sure that when possible, that from a participant service needs, that we are taking account in stock and trying to order medications, meals, and other supplies in advance so that folks have a stock, because if the roads close or there's a disruption, you may not be able to get it there that day. And so we want to make sure that you're not necessarily running out of anything during that time period when possible. And we also want to look to see if we can reschedule appointments. So if the roads around Fairmount Park are closed because of a FIFA watch party, we want to make sure that you're not scheduling anything in and around that area during that time period, if at all possible. We also, as was mentioned earlier, want to discuss the backup and emergency plans, because things will not go perfectly. And we want to make sure that there's a plan in place that if something falls through, you know who to contact and what can be done to support you during that time period. And again, we want to make sure that we're identifying points of contact for our staff, for our participants, for our providers as well. Because again, things will occur that are unintended during this time period. And we want to make sure that you have a centralized number or a centralized person to be able to contact so that we can support you, answer questions, and resolve any issues that may come up. Next slide, please. And then during the event, that communication needs to continue. As we're getting updates, particularly if they're weather updates or construction updates, we want to make sure that we're communicating that out to providers, because again, things may last longer than anticipated. There's a tunnel closing heading into Pittsburgh, the Squirrel Hill Tunnel. That's supposed to be closed for a couple weeks. It's likely going to last longer than that. And we want to make sure that we're continuing to provide updates to individuals during that time period so that they can prepare for rerouting or potential delays in certain things. We also want to make sure that we are having a centralized team that can respond to issues that occur. If something happens where a provider's unable to do something, or there's a system issue, we want to make sure that we have a means to communicate that and a team that is able to meet and discuss that and respond to it real time as it is happening. Because again, we know that things are not going to go perfectly and smoothly throughout that. And again, communication is the key lesson. Beforehand, planning during it, and communicating to everybody impacted really makes a difference as to how successful you can navigate through larger scale events. Next slide, please. And I think that's questions.
Okay, thank you. Are there any questions? None in the room? Good boy.
Hi, Lloyd Wurzer. I'm just wondering how deeply you can get into that type of planning. I mean, you've got the FIFA event, okay, you can sort of see that coming. You got heavy duty snowfalls like the one we had in the recent winter. You may not see that coming, or at least not as heavy as it was. And then totally unexpected, you know, tornado touchdowns. In Schuylkill County, where I live, we have mountains we're not supposed to get through, but it happens. How can you prepare for those things for which you really can't see coming? How does that work?
So sorry, I had to turn it on. Great question. And that is why we want to have a general preparedness plan in overall, because to your point, things happen, you know, power may go out today because of the heat advisory, right? And we have to have a plan for how we're going to communicate to service coordinators or participants and providers in that area and how to respond to that. And so we have kind of steps that are outlined in internal workflows that when we become aware of something, we spring into action and get that communication out, whether that is something that we knew in advance or something that just happened and we have to respond to it. You know, we follow a similar process if there's an emergency closure of a facility where we pull together the appropriate teams, make sure that we set up, we use internal chats a lot to ensure that we're having that instantaneous communication on what we're hearing, what we're seeing, what we need to get out to the different parties to be as responsive as possible.
All right, I know we're coming up for a break. This is Juliet. I just want to add a couple of things in response to your very good question, Lloyd, in terms of the preparedness and planning and reaction. All is contingent on what we're doing today and what we're doing now. And every service coordinator is meeting with their participant is required to both look at backup planning and emergency planning. It would be my hope that everyone in this program has, you know, looked at, visited all of the information that FEMA puts out, the Federal Emergency Management Agency, about how everyone should be prepared every day. Not to be a doomsday person, but basic standard things as much as possible should be in place. 3-day water supply, additional food that doesn't necessarily need to be heated or cooked, right? Identification of backup power supply if you're someone who relies on power for refrigerated medication, for, you know, ventilators, charging power chairs. You know, there's things that can be planned in place that service coordinators should be working in partnership with participants to identify. For providers, you should be looking at your operations planning today. Do you have a secondary site identified? Do you have a tertiary site identified? If your primary site cannot be a site in which you work. So you have to have those continuation of care and operational plans in place. We lovingly refer to it as our COOP plan here in the Office of Long-Term Living. There are tabletop exercises you can do. Lots of information also put out by PEMA, our Pennsylvania Emergency Management Agency, in coordination with FEMA. There's information specific to individuals with disabilities and checklists on what they should think about in sort of their planning, their backup planning, registration with their local fire department and emergency medical services, etc. So I know that was a lot. I know I'm eating into the break, but I just wanted to take the opportunity to say everyone has a part in that preparation now. Thank you.
Thank you, Juliet. And with that, we will take our break. We will return at
11:36?
Yes, that. 11:36.
Yeah. 1 minute. Top off your beverages, and we will get started in 1 minute. If you're an SC and you're here for the service coordinator's role in home and community-based services section, be in that area. Come towards the table at the front.
You may want to roll some of these chairs up there.
They got the
Room like is working? You want to unplug the list?
You mind?
Yeah.
Thank you.
Yeah, like. Yeah, and up here, there's chairs over here too.
So Juliet, I'm already zooming where I'm at.
Yeah.
Everybody online, just bear with us for a minute.
Let's go, folks, up here. No, we're not sitting back there. You guys are coming up here. David can sit back there.
And everybody's trying to sit in the back of the classroom.
We need you people to do the work.
Are you taking this? Juliet? This is the Community Health Choices Service Coordinator's role in home and community-based services. So we have representatives here from all of the MCOs. How do you want to do this, Juliet?
I'll go ahead and take it.
All right, I like that.
All right, good morning, folks. This is Randy Nolan from the Office of Long-Term Living. We have teams here of service coordinators and some service coordinator supervisors from all three of the MCOs. These are the service coordinators that work with our home and community-based individuals out there. As you know, last month we did the service coordinators with the nursing facilities. We're going to do a similar format with this. I'll read through some stuff initially, and then there's some design questions that came from the advisory board. I will take turns asking the questions so everybody has a chance to go first, second, and third. So I'm not always picking on making one of you go first. So we'll go ahead and get started and go through the questions itself. Just a couple things for you to understand. Service coordination includes the primary functions of providing information to participants and facilitating access to, locating, coordinating, and monitoring needed services and supports for our participants. This is done through a comprehensive needs assessment. Service coordinators lead the person-centered service planning process to identify, coordinate, and assist participants in gaining access to needed LTSS services. and other covered services in the program, as well as non-covered medical, social, housing, educational, employment, and other services and supports. It's a complete life package look at that they work with the participants on. Service coordinators must meet with the LTS participant at least once every 3 months by phone or in person to ensure that participants' LTS services are meeting their needs. Their services are meeting their needs. At least 2 of the visits have to be in person. They can be more than that. Participants have the choice in this. A participant can say, I want to meet with my service coordinator every month, and that's their request to do that, and that has to be adhered to. They may say, all right, I'm good with phone calls. I don't need to see you this month. But the assessments, all of those have to be done in person. So I'm going to go through. We'll got a number of questions. Like I said, I'll read the question and then I'll turn it over to the teams to take a talk about it. So the first question is, please walk us through a typical initial assessment with the participant and their support team. So we'll start with AmeriHealth. Remember, please give your name and who you're with so that we can caption it.
My name is Taylor Hoover, and I'm with AmeriHealth. First, we like to really build the rapport with the participant. We connect with them with the pictures around their homes, if they have pets or any interest in the home. Also, giving the best way to contact us with our cell phones, via text, phones, or emails, whatever works best for them. We like to scan the environment using our eyes and ears. We can look at the barriers, risks, adaptive equipment they have, what they may be lacking in those areas. And then we also like to ask open-ended questions like, tell me about yourself, and then clarifying questions from there, filling in the gaps with the conversation and observations that we see. We also like to show the participant and families how to use the AmeriHealth search engines for providers or physicians.
All right, PHW.
Hi, my name is Taylor. I am here with AmCord Care for PA Health and Wellness. Typically what I do for an initial assessment is I obviously introduce myself. I give them all of my contact information, ask person-centered questions. That way I can kind of get to know them prior to going out to that initial assessment. After I go to the initial assessment, I look around, see what the participant has, what they don't, and then I offer every single service that we have to offer to them. Typically, they're kind of on the fence of not wanting to accept it, and then typically by the end of the conversation, they are willing to give it a try. So typically, that is how I do the initial assessment with my participants.
UPMC.
Hi, I'm Sandy Thomas with UPMC. And essentially our assessment begins when we make that initial phone call to welcome them to the program and introduce ourselves, remind them what our program is about, and tell them a little bit about how the process works. When we establish an appointment, we talk about their location. Do they have any pets in the home? Where's the best place to park? Are there any safety concerns with entering or exiting the home? And what things they can do to prepare for the assessment, such as make sure you have your list of medications, some of your concerns that maybe affect your health and safety at home or your environment. Do you have any behavioral health concerns? So getting them prepared for the appointment, letting them know it could be a couple of hours. And once we get to the home, like the other MCO said, you're very observant. You look around the home, notice when they're being mobile throughout the home. Are they holding on to furniture? Does it look like they maybe need some medical equipment? Do they pretty much stay to one room because they don't have access to their upstairs? Could you look at, maybe home modifications? So really you're evaluating all their functional needs You're talking about their behavioral health needs. Maybe they need a referral for some behavioral health. You're looking at their cognition. Do they have some memory concerns when it comes to taking their medications? Overall, their safety and how you can enable them to live at home independently with some additional supports in place. We do take note during the assessment of any declines or improvements. And we also look at, their involvement in the community, how we can get them more involved in the community with some, maybe some social transportation if they're needing to go to church or do some shopping, help them get out and be more involved in their aging in place with their community. And then identifying their supports. Do they have family that assist them? Do they have friends? Do they have neighbors? What are their informal supports? Or do they live alone and need additional care? And talking about their backup plan, like we kind of talked about with the planning with the FIFA and the 250th, talking about their backup plan if there's an emergency, if their caregiver calls off sick, if their electricity goes out and they, rely on electricity, talking about what shelter they would go to. So it's a lot that goes into the initial assessment.
All right, thank you. All right, so the next question. How do you assess participants' goals, community engagement, and the supports needed to achieve them? We'll start with PHW.
I'm Renee Lawrence with PA Health and Wellness. What we do is this is when we gain the most rapport with the participant. We discuss their strengths, their weaknesses, what maybe they enjoyed 6 months ago. What have you done in the past that you're not doing so much now? Things that they miss doing. Help them navigate activities that maybe they enjoy doing out in their community, like going to church, stuff like that. Also discussing, sometimes one of the biggest things is the transportation. They're not sure how to go about that. So we discuss the transportation options with them, see if they have any informal supports that could possibly help them, family, friends, just people in their community that can help.
UPMC.
Hello, this is Janet with UPMC. So what we do is that we discuss everything with the participant and their care team. I like to ask the participant how their lives were when they were more active, even if they were working. Like, what do you used to do? What did you like to do when you were more mobile and in the community? We also talk about culture, family, religious beliefs, traditions, health, safety, and their day-to-day routine. The participant and those close to them are experts on what they want to live and how they want to live in the community, so it's a collaborative process.
Okay, Mayor Health.
Hi, this is Felicia with AmeriHealth Caritas. I'm a service coordinator. Just picking back on what my peers have also shared regarding assessing a participant's goals is, first and foremost, I have a lot of folks that need translation services, so I typically start there. I can coordinate a translator for you in person or telephonically. We can also look at American Sign Language, or if they need an adaptive device to talk to me, because in order to speak and advocate for themselves, they're not going to meet their goals. So I need to know where we stand in that portion of their life. If they're not able to verbalize or communicate with those resources, then I'm leaning a lot on the substitute decision maker or the legal guardian. So I typically use the tool of Walk Me Through Your Day. That's a tool that we use where you discuss what the person is doing from waking up to laying their head on a pillow, and essentially talking with them about what makes sense to them, as well as what makes them feel stable and grounded. If a walk me through your day is not really something that is really helpful for someone, we do have our formal assessments, which really help with opening up someone to really giving some answers about their socialization, who's doing what for them, etc. So if someone has a goal to have be medication compliant, I would talk with them about how to do that, and if they can in some way take some ownership of doing that, with maybe instead of going from pill bottles, let's look at a pill case, and who can do that for you, or if you could be present while it's happening. If my participant has some needs related to financial needs, we definitely will looking at giving them resources for 211, as well as find help. I just want to send and provide an appropriate foundation for them. That way they know that they can trust me.
Thank you. All right, next question. When someone is identified to need personal assistance services, PASS, how do you determine the recommended PASS hours? What tools do you use? And how do you explain and consider all of the other services available in the program? And we'll start with UPMC on that.
Hello, my name is Andrea. I'm a service coordinator supervisor with UPMC. When you're doing those initial assessments, even annual assessments, trigger assessments, when somebody needs personal assistance service, you're asking those questions, having the conversations, their typical day. What do they need for meal prep? What do they need assistance, with bathing, personal hygiene, dressing? So you're going to have those answers, information on what they perceive that they need. You're also reviewing documentation with them from like medical, somebody might just had surgery. So let's say foot surgery, for example, they can't walk currently. So you are going to look at that mobility-wise when it comes to personal assistance, needing help walking or transferring. So it's that open conversation, getting all of the details needed, talking to them what they think, but also we have a tool that sort of gives a general, hey, let's start here at, for meal prep, depending on what you need, and say you're getting home delivered meals, you might only need 20 minutes a day, but you talk to the participant, well, I would like this made, I like this snack, or due to diabetes, I need to have snacks at certain periods, during the day, so you might add time to that. Again, with locomotion, it all depends on if they use a walker, if they use a cane, do they need assistance transferring in and out of their wheelchair? So that determines how many hours, but in the end, it's that conversation with the participant to sort of guide to see what they need.
Okay, AmeriHealth.
Hi, my name is Kelsey. I'm with AmeriHealth Caritas. Kind of piggybacking off of what was just said, one of the big things that we're going to use to identify the PASS hours needed would be using the Inter-I and going through all the functional abilities that they have, having those conversations about what each task looks like, how they are helped by informal supports, and asking those clarifying questions to make sure that we have a full picture of how a task is done for the participant. We also want to talk about bridging the gap and keeping them at their maximum functional capacity. So we don't want to just get services and replace their abilities. We want to build off of their strengths and have that conversation about what other services are available that could complement the personal assistance services as well.
Hey, PHW.
Hi, this is Cammie Hollinger. I'm with Pennsylvania Health and Wellness. With the personal assistance services, generally we use the time tasking tool to figure out the times that things take. We go through and ask what the needs are for meal prep, bathing, how long everything takes, if they need help, if they can do things independently. When just going through those questions, person-centered approach, what makes it personal for them, We also try to incorporate other items that may help, like assistive technology and personal emergency response, any kind of equipment needs that they may have that help make things more make them more independent, and just really person-centered approach, talking about their needs, going through the time tasking tool and inner REI, and that's about it.
Okay, thank you. Next question. When intermittent needs are identified, like incontinence and supervision for safety, how do you work with the participant to address those types of needs? AmeriHealth?
Hi, this is Kelsey again with AmeriHealth. When intermittent needs are identified, we have to keep in mind that every situation is personalized per participant. So we want to make sure we're meeting all of their individualized needs. So we can look at other services like a personal emergency response system if there's concern about them being alone. We can look at specialized medical equipment if it's like a incontinence intermittent need. Just different services like assistive technology as well, like was previously mentioned, like a medication dispenser, different things that can complement and help in those intermittent times. We also want to look at their informal supports, if there are any that are able to help in those intermittent needs. And then we also can look at the hybrid Tempest model, where we use both the agency-directed model and a Tempest model for, say there's somebody at home that can help in those intermittent hours, like maybe or overnight, that a caregiver can't come in. So we can look at kind of using both models of care to meet their needs. Those are just some of the ways that we have identified intermittent needs being met.
PHW.
Hi, this is Taylor with PA Health and Wellness. Basically, she stole everything that I had. So I really don't have any more to add with that. That's exactly how we do it over here, especially with the PERS. I know a lot of them are doing like the GPS watches or making sure that they have the cameras and the security that they would need in the home. So I do utilize that a lot with the one provider. That way we can hit all the bases at once.
All right, UPMC.
Hi, this is Sandy Thomas again with UPMC. When somebody has needs that are identified like continence and supervision, we do work with them or work with their primary care provider to obtain any kind of continence supplies they may need as far as briefs, wipes, things like that. We also have a conversation about their personal emergency response device, making sure that they know that they can use that at all times, even in the shower, because they are water resistant. So that kind of ensures their supervision and safety even during bathing times. We can also offer assistive technology such as cameras, door alarms, bed alarms, locked pill boxes that, in case they have any kind of cognition issues or safety concerns with small children in the home, they can obtain some assistive technology for that. We also ask them about their informal supports that may be available to them that can assist them during that intermittent time and need, and or skilled care. And we also talk about maybe split shifts if they have personal assistance services. Maybe if they have an intermittent need in the morning and at night, maybe we can split their time. So, yep, that's how we address those.
All right, so we'll move on to the next question. Can you tell us what happens after the initial assessment and before plans are finalized? How do you engage with utilization management or handle situations where the total hours recommended are questioned? We'll start with PA Health and Wellness.
Hello, my name is Rakisha Green. I'm with PA Health and Wellness.
After the initial assessment, we typically have the conversation with the participant that there are other services out there besides PASS. So we do communicate with them to make sure they have an open discussion of what other services they can be utilizing during this time. I do communicate with the participant about the grievance process. So I do instruct them to, if they're not satisfied with those hours, that they have the right to appeal those hours. But I also communicate with them that whether or not they have informal supports or backup supports in place to also assist them during the time. But I think during the assessment and after the assessment, it's just a big communication with us on what to do after they're not satisfied with those hours.
PMC?
Hello, this is Andrea. After the initial assessment, again, all the questions are asked, information is taken, things are reviewed of what is, functionally needed, medically needed, and then, we proceed as a MCO to put what hours determined by, the assessments that we use forward. If, that is not inconsistent what the participant wants, we do have the, utilization management does review that, and they move forward, in their respect. Again, it's come back to the participant. This is what was decided. If you're in agreement, great, we move forward, with goals, with care planning, getting everything in place. We still do that. We still proceed with planning to make sure that, services are getting started for them, even though they might not be consistent with what the participant wants. Again, yes, the participant is able to appeal that. We assist them with that, trying, if they need to call in to say, hey, I want to start the process, I would like to request, we'll help them with that call if they need. And we follow them through the process as well, letting them know that, you'll be getting a letter in the mail, this is what you can do. But, the main thing we like to also reassure them that is, you might not be happy with the hours you receive, but you have hours in place, and let's get those started for you so you can get services and you can proceed accordingly moving on, with what you need.
PHW? AmeriHealth, sorry. Reading the wrong sheet here.
This is Taylor with AmeriHealth again. We are reaching out to providers, making sure that if it's a preferred provider from the participant, that they can confirm these hours and they have care available for this, or if we have to reach out to multiple providers trying to find available care for this participant. We also have ongoing communication with utilization management, with case rounds, and providing medical documentation to further back up the request hours.
All right, next question. A little bit of a long question here. If a participant identified an anticipated temporary change in condition, such as an upcoming surgery with significant supports while they recover, or a primary caregiver informal support not being available due to a business trip, a vacation, which requires some significant changes to supervision for the participant, how do you plan for these events and address them in a person-centered service plan? UPMC?
Mendoza for UPMC. So we always look at the backup plan first, but if other informal supports can cover the new needs, we can approve temporary services, or we can also look for respite. We have a discussion with the participant and their care team to find a strategy that aligns with their needs, goals, and preferences.
Okay, AmeriHealth.
Hi, this is Felicia again from AmeriHealth. Typically, when a participant or the family contacts me regarding a temporary change of condition like a surgery, I'll talk to them about what's the timeline? When is the surgery going to happen?
how long is the recovery period for our participant? And then just like my peer just spoke on, what's the backup plan? If it's a scenario where a participant's natural support, let's say sister has been taking at the participant for a while and they just are engaging right now in caregiver burnout, we can offer a trigger assessment. I'll talk to the sister, talk to the participant, to figure out what has the sister been covering for the participant, so that way there's a smooth transition for what the expectation is for the agency or Tempest to cover. And also, again, if a situation arises where a participant calls you on the phone and says, hey, I forgot to tell you, I'm in the hospital. I'm going to be home probably tomorrow. You can, again, do a temporary increase of hours, but then we will circle back to the participant to just check in, and if necessary, we might also have to do another trigger assessment. Because, as always, what's most important for our participants is safety, advocacy, and independence.
Yeah, PHW?
So when any of my participants have a temporary change in condition, we always discuss that with them and try to get information from the primary care doctor to clinically support the temporary increased needs. Then we'll put it in as a request for an increase in hours if we can't find informal supports or backup plans to cover it. Like Felicia said, we circle back with them and see if they still need the increase, and if they do, we would do a trigger assessment then for a longer time period. Also, respite, I've used respite a lot in a facility for my participants that have family members that just need a break, that are going on vacation, and we have used short-term respite in a facility quite a bit. And that's about it.
Thank you. All right, next question. How do you manage your caseload and time? How much time does it usually take to finish up tasks needed from the initial assessment, such as documentation, referrals, or gathering additional information? AmeriHealth?
This is Kelsey from AmeriHealth. It's hard to put a set time on those things because everything is very individualized, and our work with everyone involved is ongoing. So we have to stay a little fluid. We have to not put time limits on anything. We just have to worry more about time management. So that's just part of the service coordinator role, and understanding how to manage your time and, account for those times that might go a little bit past what you expected. But again, it's mostly about being in ongoing care management and being fluid with your caseload.
PHW?
This is Taylor again with PA Health and Wellness. The way that I manage my caseload, honestly, as soon as I see something come into window, if it's a visit, an annual, a COC, it doesn't really matter. I am reaching out to that participant as soon as it comes across. That way, I always stay ahead of the game. Normally, whenever I speak with the participant, I am asking them what changes they want to make, if there is any changes. That way I can have that in my assessment, pre-drafted, ready to go before I even leave my house. Typically, whenever I get to a participant's house, if for some reason they change their mind by the time that I get there, what I do is I can just update what I had already put in, and normally I already have my assessment submitted and ready to go before I even get back home. That's just the way that I like to do it, just because a lot of my participants call me, text me, email me. I am very close with all of my participants, so it's just easier for me to do it that way before I go to the assessment and just verify everything at the assessment. That way I can stay on top of all of my other participants at the same time.
UPMC.
This is Sandy with UPMC. how we manage our caseload and our time, we have system tools in place that prioritize our tasks. And yes, there are times that you have several critical tasks going on at the same time. So how we manage that, if, we have a new to LTSS to see and we have critical incidents and we just have all kinds of things going on, we rely on our supervisors, our team, because we do back each other up and assist with prioritizing our caseload. I also, other than, system tools that help us and our teams, we have our calendars, and I do a lot of color coding so that I know green is in person, blue is travel, hot purple is critical. So I do a lot of color coding that helps me plan my days. As far as how much time it takes to finish up initial assessments, they do vary. Like someone else said, they vary by participant because there is a lot of documentation, and one person may have more referrals than others. And, of course, we like to educate them also on next steps. Now that the assessment's over and we're working on your care plan, let's have a little bit of education, making sure they know the numbers to call for member services, for their service coordinator, how to contact our 24/7 nurse line so that they're avoiding going to the emergency room all the time, how to identify contacting adult protective services or older adult protective services, and just letting them know the process. Now that we're done here, you'll hear from me every quarter, and I'll be calling, and then I'll stop in, but I will make appointments with you, and making sure they understand it's important that they answer their phone, it's important that they sign necessary documents that come in the mail, and just letting them know you'll be staying in touch.
Hey, I think that was the last of the questions on here, but I'm going to go ahead and ask another one anyways. What are some of the biggest barriers or frustrations that you guys have in your day-to-day work? I'm hoping somebody chimes up, or I'm going to call on you.
And you can't say none, because I used to be in the SC business.
Housing.
I'm going to start calling by names if you don't talk.
Trying to locate. You get that new participant, and trying to locate sometime is a barrier. You're calling them, you're calling any numbers that you're aware of, you're doing that pop-in visit. So trying to locate to make sure, health and safety and getting services in place.
Hi, this is Steve with AmeriHealth. You haven't heard from me yet, but you've heard from several of my associates here. As a former service coordinator myself, I would probably say one of the biggest challenges is often getting a lot of buy-in from our participants. There's a lot of services out there that they have available to them. There's a lot of natural supports both within their families, within the community, and within other just avenues of support that are available to them, but a lot of people get kind of locked in on, I need POS hours, I need home care services, and some of that is related to, I think at least, family members wanting to become paid caregivers for their loved ones, which is certainly an admirable goal, and I applaud people who take that on. But I feel like a lot of people get locked into this, I need a certain amount of hours in order to make ends meet, I need this, I need that, when really what they're talking about is a lot of wants. And the biggest barrier that I found was always kind of breaking that wall down of, these are things that you want, they're not necessarily things that you need. We need to focus on the things that you need and try to find other ways to support you with those things that you do want that maybe outside of the scope of our program. We can certainly use the tools that we have available to us to fill in those gaps, like we've all said before, but getting that buy-in from those participants to kind of seek out and participate in those other avenues of support is one of the things that I found to be the most challenging things.
This side of the table?
Yeah, split up. Okay. Hi, I'm Renee Lawrence with PA Health and Wellness. One thing I noticed is transportation. They don't want to take public transportation, and sometimes it's really hard to kind of convince them to make that step and do that. A lot of times, reasonings they don't want to take it would be because they're, taking the rabbit bus and they're on there for 4 hours, and they had a 20-minute appointment that was 20 minutes away. So it's kind of like a barrier there. You're not sure how to convince them, especially if you're in the city. They only have, public transportation, rapid transportation. Even out in the country, it's even harder. I know as you go up north, there's nothing. Rapid doesn't even do a lot of the areas that I, go to see. So trying to convince them to try public transportation, or even talking to them about informal care, trying to find caregivers that are willing to do it without, getting compensated for it. Sometimes it's a tough bargain.
All right, Matt, I'm going to turn it back over to you to see if anybody has any questions for these folks.
Does anybody have any questions?
From subcommittee.
From subcommittee members.
Kind of blown away by that presentation. Any subcommittee members have questions?
Hey, this is Pam. I do.
Go ahead, Pam.
Okay. I actually have a few, but I'll start with this one. This is a question I have wondered about for years. When you're completing the time and task tool, how do you come up with the amount of time for each task? Does it get fed over from the response in the NRI? So, for example, if the person was assessed as needed extensive help with bathing, does that feed on over into the time and task tool, and the amount of time that is associated with extensive help with bathing gets fed into the time and task tool? Or do you ask the person again, how often do you bathe? How long does it take you to bathe?
Hi, this is Sandy from UPMC. Yes, it does feed from the NRI to some extent, but we do have the ability to take into account, for instance, shopping. It may, during the assessment, the person may need some assistance with shopping, and it may come back and suggest, an hour a week for shopping. But we know that person lives in a rural area, far further away than normal from a grocery store, or they require fresh foods for their diabetic condition, and they have to go 3 times a week. So we can request to increase that, but of course we can always seek guidance from our supervisor. Does that kind of answer your question?
Yeah, that's really helpful. That's really helpful. So, but in the first instance, like the number comes over and is kind of fed in from the NRI. Is that right?
Suggestion.
I'm sorry, what?
It's just a suggested amount according to how we assess them during for their functional need. Whether they were independent, needed a little support or some extensive support, depending on how we assess them, then it does carry over to that.
Thanks, and I appreciate the addition about making adjustments for things like the shopping. Thanks.
Welcome.
Can I just follow up that? How much discretion then do you have? I know the thing suggests stuff. I'm not trying to put you on the spot.
I'm not quite sure how to answer that. We really ask a lot of questions about, like, for instance, shopping. Okay, so you're, 20 minutes away from a grocery store, but it also takes you 10 minutes to get into and out of the vehicle because of your, physical ailments. I work with them and discuss exactly how long they think it takes to take one shopping trip, and justify that. You know, let's say the time and task tool says, oh, they should get an hour a week, but we think it should be 3. We can advocate for that in the time and task tool and speak with our supervisor about it. But ultimately, it's up to, you know, utilization management if it's not agreed upon.
So the supervisor has discretion.
Yes, I would.
So Stephen, aren't you?
We can have that conversation. This is Andrea with UPMC. You know, you're also, when you're in the home, say you're talking, you know, I know Sandy was discussing shopping, but say you're looking at locomotion, mobility, you know, you're also observing. So say you go to the home, the participant answers the door, walks from the door to the living room, fine. You're having that sit-down conversation with them after, you know, doing the assessment, and they said, I need extensive assistance with locomotion. Okay, let's have that conversation, but you're also observing, I saw the participant walk unassisted, you know, so there's a lot of things going into play. So you might be thinking, yes, they might need 10 minutes a day to help with locomotion, maybe for transfers or getting uneven surfaces, things like that. They're saying, no, I need assistance 3 hours a day. You know, so that's where that sort of conversation comes into play. But then you're also reviewing, you know, does that help?
Hi, Lloyd Wirtz again. My primary role is that of a behavioral health advocate. My dad was mentally ill. I worked in the field pretty much all my life. Sometimes, of course, your consumers, your participants are going to come in with you knowing what those behavioral health needs are in advance. And that's good. Hopefully, you'll be able to provide service for them. But for when behavioral health needs crop up between services or pretty much unexpected, and they sure as heck can, how long does it take before you're able to get out, get in there, assess, and then get the services needed to the individual involved? Do you have an idea on that?
So this is Taylor from PHW. One of the things that we do with our service coordinators, and we talk a little bit about this with temporary increases, if we get a call and identify there's a need for a temporary increase, that service coordinator can actually submit for that temp increase before they can get out to the home to ensure the safety of the member. So we try and get them out as soon as possible. But until that time, we can put those services in place to make sure that they're safe, then go out and identify, okay, you need these hours long term. What other supports in the community can we offer you? What other waiver services are there? So we're actually able to do that temp increase up front, you know, as soon as possible to make sure that's safety.
Thank you so much for not pointing the finger at home massage. I really do appreciate that. Other thoughts?
Yeah, hi, this is Steve with AmeriHealth again. You know, we use a suite of assessment tools throughout the entire process and along with motivational interviewing. And when we do identify behavioral health needs, one of the things we want to make sure we're doing is we're addressing those behavioral health needs as quickly as we can, whether it be through referrals to our internal behavioral health service coordination, community resources, local county-based mental health services. But there are certainly times, and I can attest as a service coordinator that there are times where behavioral health needs and sometimes physical health needs kind of trump what's going on at the assessment process. You know, if somebody, and I've said this to my team members, if somebody's in the middle of a behavioral health crisis or a medical health crisis, when you're out to do an assessment, that kind of takes priority. We can kind of shift our focus and you know, provide that mental health first aid or that medical kind of support and kind of get them to a position where they want to be. From a medical side, for example, I worked with one participant who I went out to do her initial assessment, and she lived with diabetes. And when I went out to meet with her, she was having a really hard time, was really anxious, constantly checking her blood sugar. Her blood sugar monitor, she had a continuous monitor, and it was constantly saying that she was low, despite the fact that she was, drinking a lot of orange juice and eating canned fruits and doing everything she knew to do to keep her blood sugar up. So in that moment, I paused and I said, hey, why don't you do a finger stick? And it turned out her blood sugar was actually like over 300 and something. So that's just an example of in the moment where, right now maybe doing the assessment to get these services in place isn't the priority, getting them that medical help that they need. And it's the same for behavioral health. If somebody's at an assessment and they're actively having a behavioral health crisis, whether it's they're feeling suicidal or expressing suicidal thoughts, we want to be addressing that. I fall back on the phrase that it does us no good to get services in place if the person isn't there to receive them. So you got to take care of those priorities first.
Thank you so much.
All right. This is Allie Cronley with SEAU Healthcare PA. I have 2 questions. I hope you'll let me ask both.
Allie, I'm sorry. This is Pam. Can I just interrupt for a moment? On my question that I asked before Lloyd's question, we only got an answer from UPMC. Could we just go back and get an answer to my question from the other 2 MCOs? I just don't want it to get lost.
Yeah, I think we're going to do some follow-up because in the interest of time, we only have so much time, so I'll have them provide follow-up afterwards because I think we should get to sort of more questions as best as we can, if that's okay.
Okay, sorry,
Juliet,
Pam.
Juliet, I'm sorry. I've been wanting to get an answer to this question for years, and I actually could we just let them quickly answer that question? I'm also hearing from other advocates in the text that it's an important question to them too, because we hear really inconsistent, different things at hearings about where the numbers in the time and task tool come from.
Certainly.
Thank you.
You probably would because each of the MCOs can use their own time and task tool and do their process differently. So it's not a standardized process that comes from the Office of Long-Term Living. So there are going to be differences. So
right. So that's why I would really like to hear from the other 2 MCOs.
PHW.
This is Taylor from PHW. So our hours come specifically from the service coordinator, based off of their conversation and what they see while they're in the home. So for each of our tasks, the service coordinator is able to give us a justification for how many minutes that task takes for them, how many tasks or how many times per day they do that task, and how many days per week. We also use that tool to identify what they can do independently by themselves, what they have informal support for, and any of the other services that they're currently utilizing from the waiver. So our service coordinators are really justifying that number for all of our participants, sending that over to UM, and then on the PHW side, all of our pass hours, regardless of the total, are reviewed by our medical directors. They're the ones that are making that decision, and then that letter is sent out.
Did the specific answers come from the InterRide responses, or do they ask them how long does it take you to bathe, for instance?
So they're talking to the member to ask them how long it's taking them to do those specific tasks and walking through. If they feel that time seems to be a little bit excessive or more than maybe they would think that it would take, they ask additional questions to really get to that number of what the true need is.
Thank you.
Mayor Health?
Yeah, this is Steve with the Mayor Health again. So we have our own internal tool that we use as well. But we use that in concert with the Walk Me Through Your Day conversation that's incorporated into our assessment process to identify how long it takes for a particular task to be completed, both based on the self-report of the participant and the service coordinator's observations. We also try to balance out with the want versus the need. Again, a lot of participants might want a lot of services in a particular for a particular task, but maybe the need is maybe it's a little bit more or maybe it's a little bit less. So we do have the opportunity to both report what the participant is requesting or saying they need or want with those particular tasks. We also have the opportunity for the service coordinators to provide their suggestion based on their observations. All that gets looked at along with what's medically necessary and what meets, criteria for services for our team to make their decision. And of course, the participant feels that what is approved doesn't meet their needs, they do have the right to appeal that decision.
Is the initial number, does it come over from the inter-I, or do they separately ask how long does it take you to do this task for the time and task?
The initial numbers are reported primarily by the participant to the service coordinator, and then service coordinator uses their observational skills to make suggestions from there.
And this is the last question of the follow-up question. So they'll ask them once about their bathing needs for the inter-I, and then separately, when they're doing the time and task tool, they'll say, how long does it take you to, for instance, bathe?
I mean, I can't speak for each individual service coordinator and how they run their assessments, but I do know a lot of coordinators are kind of doing multiple assessments throughout that entire process. So while they're completing the inter-I, they're doing that walk me through your day. They're keeping that time and tasks tool in the back of their mind and gathering all that information at once.
Okay, thank you. We're going to move on with questions. Go ahead, Allie.
Hey, good morning. I super appreciate you guys being here and feel like this is really valuable. I think the role that you play in the system overall is totally important and critical, and the description of your attempt to balance your caseloads, I think probably was very calm, and appreciate the work you do. So I mean, it's clear there's a lot of interest and discussion, and be happy to, saying this to the folks leading the discussion, like happy to do more of this at different times too. So I have two questions. The first is about participant direction, and just in the long process that you guys talked about in terms of assessment and finalizing care plans. I didn't really hear much mention of it beyond the sister here around Tempest as kind of a hybrid model for caregivers who are interested in having intermittent needs met. So I'm curious, obviously participant direction is required to be offered as a first choice in the system. If you guys could just talk a little bit about how you present participant direction, how you share that information. We know that the service coordinators are really the only place that participants ever receive information about participant direction. So curious if you guys could just all speak to that.
UPMC?
It's a discussion in every assessment that we do, and that's a given. It's in our training. I know a lot of, just from personal experience, when I was an SC, they didn't know about it. It was like, oh, I'm allowed to do that, or I can do that. So definitely education is a key for that. I also see, or I have seen, there's a few more steps to take for participant direct, getting hired, the common law employer, things of that nature. So I know sometimes people are a little bit hesitant of, wait, I can just go to a provider, get my caregiver signed up, I'm good, or get a caregiver, I'm good to go. But again, it's that education is key, and essentially their choice as well.
PHW?
Hi, this is Mike from PHW. So it's one of those things that we even start in the beginning with training SCs to have that conversation with not only every assessment, but every contact we have with the participants, because they don't know what that is, and it is our role to let them know that it is an option, and it's an ongoing option, and you can choose that option at any time. We also provide a little one-page pamphlet on it, something that they can have in their home, so it's just kind of a reminder that if you do have somebody, that in mind, or there's other options, if you don't have somebody in mind, we can help find that to bridge that gap. And it's also it's really valuable in the rural areas as well, because there's not a lot of agency in those areas. So that's something that we always are striving to have that conversation with them and to get the information so they understand.
AmeriHealth.
Yeah, Steve with AmeriHealth again. We do a lot of the same things that my colleagues here have shared. It starts with conversation and training with service coordinators. We're having those conversations with the participant not only at their initial assessment, but at every assessment afterward, and even in between, making sure they're aware they have that opportunity and that they can make that change from an agency model to self-directed at any point in time.
Thanks, just really appreciate that. Can I ask my second question?
Real quick, before we do that, two things. One, just a point of clarification, participant self-direction is the first option to be presented when PAS is indicated as a service need, not across the board. So, because while the majority of participants do use PAS or have PAS, personal assistant services, as a need, not everyone does, not everyone uses it. So for folks who are listening in, I didn't want you to get the wrong impression that participant self-directed PAS is offered to everyone. It's not. It's supposed to be the first model option when personal assistant services is an identified service to meet a need. And then we are halfway through public comment period, but I defer to you now.
I mean, this is just subjective. I'm kind of building on, I think is it Steve? I just want to build on something you said. I'm curious the degree to which you feel like you're increasingly or decreasingly or the same, whatever, seeing people who are kind of entering into the home and community-based services already having an agency provider like identified or having already I mean, I'm just kind of speaking to, like, there's a lot of advertisement, like, get paid to take care of your mom. You know, like, to what degree are you feeling like what % people are sort of entering the system through those pipelines as opposed to maybe, like, a referral from a doctor or something similar?
Yeah, it's a great question. And I other than speaking anecdotally, I wouldn't be able to give you hard numbers on that. So if you're looking for hard numbers, I'd have to.
No, I was asking anecdotally.
So again, we're trying to have those conversations about self-direction of their PAS services whenever possible. I don't know that I could speak 100% confidently on how much of an increase or, a certain percentage of participants that are enrolling with an agency already identified or plans in place. I would probably defer to my other colleagues here who might be able to speak on that a little bit better than I.
In the interest of time, though, we are in public comment. George has a question here, and then Paula and Pam, are there any questions online? I'll just leave it to you to set up a queue for that.
Thank you again so much for being here. I'm George Fernandez, subcommittee member. Someone mentioned housing on that side of the table. As a minority developer, I'd love to hear a little bit more from you or from any of the plans. What are the challenges around housing? Is it landlords not participating in affordable housing? Is it not enough housing units being available? And from a housing question, are you finding any of your members really close to being homelessness or experiencing homelessness because of whatever challenges they're experiencing?
Yes, and yes to everything you said. I have people. Obviously, most of our folks they have limited income, and limited income housing is very difficult to get. The waiting lists are years long, and other than that, which is very, very common, we also have people living in, for example, a third floor, and they want to live in a first floor. Same situation. Very difficult to find, very difficult to get. I don't think it's that the landlords don't want to cooperate. I think it's just availability. It's not there. So I think that's the issue here, is the lack of affordable housing across the board. It's not a specific problem about people not wanting to do it. It's just we don't have them. They don't exist.
PHW?
It's Mike again. I would agree with that. It's the financial constraints, and not enough availability. We do have people that want to live in their homes longer too, but they're not available for them any longer. So I don't know where else we can turn as far as affordable housing.
Hey, Mary.
Just kind of echoing everything that was already said. The availability is very hard to find in the areas that I'm having people experiencing those close to homelessness issues.
All right. Thank you, folks. I want to give you my appreciation for you guys coming in, taking the day to come in here and visit with us and be able to provide some information and for the committee. I truly appreciate you and the work that you do and the time you've done today. So thank you guys very much, and I'll let you guys go and we'll move into public comment.
So in the interest of time, I'm just going to go through the questions that I can see. If there are questions specific to service coordinators, we'll follow up with the CHC MCOs, as we stated earlier, in our usual fashion. You guys stay here, you can go get comfortable, either or. Just a comment from Kelly Barrett, who wants to share that as a person who has spent time in a nursing facility and had a barrier of not enough caregivers to discharge, I want to reiterate that successful community living cannot happen for people with significant disabilities if the caregiving workforce is not appropriately funded. Right now, it's grossly underfunded for folks who choose agency model. What is the plan to create equity for consumers who choose agency model over consumer directed? So thank you for your comment and your question. So as you know, we don't have a budget. The General Assembly is working on that budget. It is for them to answer with regards to the funding. With regards to equity on participant self-directed and agency model, I'm going to make the assumption you're referring to the investment that Governor Shapiro made in participant self-direction of the $21 million that was passed in this last budget. That investment was actually to create equity between the participant-directed services and agency model, where it was identified in particular that direct care workers and participant self-directed did not have sort of compensation considerations for things like health benefits or for things like personal time off, that a person who was at an organization meeting full-time benefits would have, and that were built into agency assumptions. So I just wanted to kind of level set that for folks who were thinking that investment was creating inequity. It was really the reverse, right? It was recognizing that those assumptions that go into different rate setting were not necessarily there for our direct care workforce. But I would say that, you know, we agree at DHS that caregivers should and deserve a living wage. So we do hope that we are able to move in that direction. All right. Kate, there's a lot of questions and comments that we will take note of, and we're going to respond to some of them. I'm going to go from the bottom up, just in case you don't hear me get to all of your questions, but we will certainly do follow up. Can OLTL provide a list of the state-directed payments? Any and all approved state-directed payments for CMS are available on the CMS website. We will ensure that that link goes out. You can sort by state, so that would be the easiest way to look up all of Pennsylvania's state-directed Medicaid payments, be them payments for OLTL or other of our sister offices. From Mia Haney, given the significance of the proposed changes to the state-directed payments, stakeholder alignment is important, and while organizations may ultimately reach different conclusions, understanding the Commonwealth's position before the federal comment deadline would help stakeholders provide more informed and coordinated feedback to CMS. For example, one potential recommendation would be to ask CMS to clarify that the proposed changes apply only to state-directed payments requiring prior CMS approval rather than all state-directed payments. Such a clarification could help avoid unintended impacts on Pennsylvania's OLTL rate floor or the ability of MCOs to continue implementing value-based payment arrangements with providers. However, if the Commonwealth intends to pursue a different strategy, stakeholders would benefit from understanding that approach before submitting comments. Will OLTL be sharing its proposed comments or policy position with stakeholders prior to the CMS comment deadline to help promote thoughtful and aligned feedback? In short, no. We are not sharing draft comments prior to their finalization and submission to the feds. And I certainly understand and welcome the desire to be aligned with us. That it's just not kind of how we operate. We want folks to be able to provide, where they stand and what they stand for and what's important to them. What I will say is that, putting caps on state-directed payments, right, that was discussed, that has significant impact. So not having caps would be a good thing. I think it would be allowing states to continue to have the flexibility to design and develop state-directed payments that meet the needs of our individual states. When you see one state, you see one state, and there's good reason for that. Our populations are different, our resources are different, our cultures are different, and you can go on and on and on. But I do appreciate that, and we'll get back to you on that. All right. So we have handouts that are connected. We sent the link out for the court case. Kimberly Sharp has noted that currently there are no providers available listed on the telehealth cognitive rehabilitation therapy in our directory. She knows that providers need to go through validation to get signed up and become available in HCSIS, and that's also required for the new telehealth services that must go through validation to build out the provider networks. So just for folks' awareness today, providers who are out there, a listserv went out today from the Office of Long-Term Living, Kim Barge's team for provider enrollment, talking about the approvals for the waivers and the programs and how to enroll as a provider of telehealth services. For providers who are already enrolled within the Medicaid program and Office of Long-Term Living, there is an expedited process. It's called adding services. So if you add a service, you don't have to go through all of everything over again. You do also, after you change your service with us, still need to meet all the credentialing requirements of the various CHC MCOs, and certainly that is part of that process. We recommend you take a look at that listserv, and we do encourage, eligible providers to please enroll with us. We are eager to get those networks up and running and deployed. Okay. Jeff Eisman had two CHC MCO housing questions. The first question is, can the three MCOs comment on how they address housing needs, such as home repairs? Second, what about healthy housing needs for those with multiple chemical, electrical, or environmental sensitivities, mold, allergens to certain types of building materials, etc.? So we will send that question out to each of the three CHC MCOs for a follow-up response. I can say, generally speaking, Jeff, that from OLTL's perspective, the SC service coordinators are to help them connect with housing supports for housing repair programs. The waiver program does not cover housing repair programs, except for some very, very limited situations whereby it might be connected to an environmental modification when there needs to be a change to an egress or something related to sort of the power upgrade. But those aren't really considered repairs so much as they are part of a home modification piece. But service coordinators should be assisting with finding, wherever possible, home repair resources, but it is not currently a covered waiver service. But they can certainly respond to that. Okay. So a question that the CHC MCOs will also receive is for service coordination. When you've had consumer hours reduced by a medical director, does the medical director have a conversation with the service coordinators? Are conversations occurring, or are there just emails going back and forth explaining the situation? So if the CHC MCOs can provide some more information on that, we will send that out and have that out. Rico Shepard has submitted some comments. One, increasingly we see that the MCOs have follow-up items after the comprehensive needs assessment. For example, a request for further documentation from their doctor to justify the personal assistance services. Specifically, there seems to be a higher standard to support supervision, even after hearing input from the caregiver about the participant's cognitive impairments. Who is responsible for helping get that medical documentation following the comprehensive needs assessment? How much time is reasonable for the documentation to be returned? If it's not the SC who's responsible for getting the medical documentation, what supports are available for participants with a cognitive impairment? So we will get that question out to the CHC MCOs for their follow-up. Number 2 from Rico, can each CHC MCO please provide comment as to how routine support services are accounted for in PAS calculation? It would be helpful to specifically address how tasks such as pain management routines, like applying heating pads, lidocaine patches, massaging limbs, assisting with taking on and off compressions. There's a whole bunch here, so we're just going to send that out. Very good question. But we will make sure the MCOs have that question and a response back to you, Rico. All right. Joey Mentry commented of having significant interest in hearing MCO answers to Allie's second question on how many consumers are entering the HCBS system with an agency provider already identified. Can the MCO answer this question as a follow-up to this meeting? We can certainly give it to the MCOs, but, I will go back and have a discussion with my team to see if we, OLTL, might be able to get a more accurate answer for you, given that we, OLTL, engage with the Pennsylvania Independent Enrollment Broker as one of our vendors, and we may be able to get a better sense of folks coming into the process already identifying some of those things, or we may not. I'll follow up with my team, and we'll follow up with the MCOs as well. Jeff Eisman asked about OPSA, the Older Adult Protective Services legislation that is moving through the General Assembly. And the question was related to what was OLTL looking for, and can we offer comments about what we hope for with regards to this legislation. What I would say, Jeff, is that back in September of 2024, OLTL had participated in the hearing on the Older Adults Protective Services Act. And so, that testimony should be available. That can go further in depth into DHS's priorities and wish lists for the OPSA legislation. But I can say right now, one of the things that we looked for and one of the things that we hope for is alignment between adult protective services for 19 to 59 and older adult protective services for those over the age of 60, because your protections should not change because you got a year older. So that is one of our hopes with this legislation, is that we get alignment in those definitions. We get alignment in certain processes and expectations. Now, first step was OPSA being modernized, and then following that would be looking to Act 70 of 2010, maybe then following suit, because there are very big distinctions between Act 70, which is Adult Protective Services, and the Older Adult Protective Services Act that is currently going through. One of the key ones is Adult Protective Services for 19. We don't substantiate perpetrators. Our mission is to go make sure the person is safe, see what the person needs in order to be safe, and address those immediate needs. Older adult protective services, they have a whole addition of substantiating perpetrators. We leave that to law enforcement in the Office of Long-Term Living. So if we suspect a crime or anything like that, we make the referrals to the law enforcement to take on that piece. We don't do it. So that's a big distinction between the two. So those are all of my comments there. Matt is looking at me, giving me the stare down, so I will hand it over to him.
I will note that the next meeting is Wednesday, August 5th, same place, same time. With that, I would accept a motion to adjourn. Is anybody left?
Motion.
George, thank you. We're adjourned.
Thank you all.